and then I can take questions later. And I think the meeting is being recorded. Okay, great. I apologize. I'm just recovering from a little bit of a cold, so my voice is a little strange. But thanks so much, everyone, for being here. My name's Lucy Federico. I am one of the outpatient palliative care docs. Hopefully, have crossed paths with many of you before. But yeah, it's a pleasure to be presenting it to you today. Really, what this presentation is focusing on is a quality improvement initiative that was undertaken over the last year or so, and the title is Timing Matters, Patient Perspectives on Outpatient Palliative Care Referrals. So without further ado, we will get started here. And just to say, there's no conflicts of interest and nothing financially to disclose either. And I really just want to give a huge thanks to all of the Odette malignant outpatient palliative care docs for all their support in this project. It was really, really appreciated. So in terms of our outline today, we'll talk a little bit about actually an introduction to our team, or more so a reminder, and then an introduction to the study, go over a bit of the methods, some results, main takeaways, and then discussion as well. So who is the outpatient malignant palliative care team? So first of all, you're probably very familiar with the fact that we provide care in the Odette Cancer Center and the Louise Temerty Breast Clinic, where we're integrated into the clinic. And in terms of our current team, we have doctors Christine Lau, who's the team lead and is on the call today, Madeline Bates-Dugan, who is the breast lead, Lise Wynn, Giovanna Siriani, and Adam Merlot, who also works in the breast clinic as well. You may see my name is not here, and that's because I was working with this team the last year, and now I have since moved on to the non-malignant palliative care world, mostly in the ALS clinics. So I miss this team very much, but yeah, they helped me a lot with this project. And we're so very lucky to have nursing support as well from all the nurses listed here. So Crystal, Macy, Serene, and Taryn, they really help us out a lot. And that's our team. And so just a reminder of who do we actually see. While we see patients with an established active diagnosis of cancer who are followed by an oncologist at Sunnybrook. And in terms of the most common reasons for referral, usually it's around symptom management, specifically related to cancer or cancer treatments, goals of care discussions, arranging palliative supports, among other things that we can help with. And just a reminder about how to actually refer to us. So for non-urgent referrals, we just ask that you place a referral through CPOE in SunnyCare. And then for urgent or same-day referrals, it's actually going to be a chance to call locating and just ask to page the outpatient palliative care pager. The docs rotate who is in that position on a daily basis, so you'll get whoever is on for that day. So that's how to place the referrals for us. And so I just wanted to highlight that, our team has been growing, and this is also evidenced in the volumes that we've been seeing over time as well. So from 2016 all the way to present day, you can see there's been a general trend in terms of increasing volumes, with the blue being follow-ups and the green being new encounters. And, I think it's important to say we don't fully know the denominator here. I think Odette overall has been growing, but I think nonetheless, our team has been seeing increased volumes as well. And so it's really exciting, but just a good chance to kind of reintroduce our team as well because of that. So now getting into the actual study at hand. So I think that probably everyone on this call is familiar with the fact that there is a benefit of early referrals in palliative care, and this is very well established in research. And past research has shown improvements in quality of life, physical and psychological symptom burden, but even with survival with early referrals to palliative care. But I think the thing that was really, our question and what we were thinking about was that less is really known about the patient perception. So, what do patients actually think about the timing of these referrals, specifically in the context of ambulatory palliative care? So that was our question. And so I looked at the literature to just see what is already out there on that specific patient perception within ambulatory care. And so one study conducted by Wong et al. In 2019 demonstrated that, overall patients in their ambulatory clinic that was integrated into a cancer center felt like the timing of referral to ambulatory palliative care was appropriate and overall helpful. I should say that within this study, the timing of actual referral to ambulatory palliative care and then death of the patient was about 10 months, and that this finding was significant across ethnic groups, across ages, across types of cancer. So there weren't any significant differences between those groups. And the other thing that they found is that the patient's perception of an early referral was also associated with a lower reported symptom burden. So they were actually feeling benefits from their perception of an early referral. There was another study by Tagami et al. That was published in 2021 that actually interviewed bereaved caregivers for patients who had already passed away. And they had found that the timing of referral to ambulatory palliative care was appropriate, or actually in some cases too late. But interestingly enough, again, caregivers who felt like the timing was appropriate were more likely to perceive that the patient had had a good death. So I think all through these studies, it's just showing that, that patient perception, the patient voice is really important, and it actually could potentially even lead to better outcomes as well. So I think, overall, we felt like this was a really worthwhile thing to be looking at for our own local population as well. So that's just to say that previous research, sort of in the same lens, has already been conducted within our team. So in 2024, Dr. Siriani led a quality improvement project that looked at the patient perception of length of time from referral, so when the actual consultation was, put in, to then when we were actually able to see them as a team. And through two PDSA cycles, they found that 85% of patients felt like the length of time between that referral to consultation to when they were actually seen was just right. And so we wanted to kind of take all of this together, build upon this idea of really looking through the patient's eyes, trying to understand their voice in all of this. And that led us to our question of how do our patients with a diagnosis of cancer perceive the timing of palliative care introduction in the outpatient setting? And so that's what we sought out to explore. And so, in terms of our aims, our primary aim was really just that. So, understand how patients in the outpatient palliative care clinics at the Odette Cancer Center, as well as the breast center, perceive the timeliness of their referral to palliative care. And the secondary aim was more so to look at, how do patients feel, like, do they feel that there are any benefits from being connected to our team within that time frame? So that was the secondary aim. And so what did we do? So we had two Plan, Do, See, Act, or PDSA cycles. One was taking place last year, and then one was just a bit shorter and was earlier this year. And so I'll get into those cycles now. So with the first cycle, in terms of our population and who we included, we decided to include patients from all cancer sites, so Odette and breast, who had a consultation by the outpatient palliative care team, and were subsequently being seen for their first in-person follow-up appointment. And so the reason why we chose that first in-person follow-up appointment as really the time of intervention is we felt like it was, enough time that the patient would have had a bit of connection with us to see maybe what our team is all about, but not too long that they forgot what it felt like when they were first referred to us. So that was the target population. And in terms of our exclusion criteria, we did exclude patients who were not able to fill out the survey on their own. So this include those that would need help from a translator, caregiver, or other person. And as I mentioned, in terms of the location that this took place at the Odette Cancer Center, as well as the breast center. And so the intervention was really a delivered paper survey. And so just kind of show you what that survey looked at. And I'm sorry, it's a little blurry, but I will say that we did come up with this survey together as a team, and we also ran it by a PFAC member to sort of vet the questions to make sure they felt appropriate for our palliative care patients. And so the first question here hinges on that timeliness question. So was the time at which you met the first met the palliative care team too early, just right, or too late. And then there's a section below for them to provide a comment. And then there were only two other questions. The second question was all about any perceived benefits that they felt, or conversely, no benefit from being connected with our team. And then again, a section for them to provide a little bit of context there if they wished. And then question three was we wanted to see what they felt like was the most helpful topic that they've discussed with us. So we asked them to go back and circle the most helpful topic that they found so far. So that is the survey that we provided. And so in terms of the intervention itself, so the physician would first identify any eligible patients at their first in-person follow-up appointment, and then they would consent the patient to the study. And then we did have a disease site code, so the physician would actually go in and circle the disease site code right there on the survey so that we could track it and then provide it to the patient. They would leave it with them along with a collection box. And then after the patient was finished filling out the survey, they could put it in the box. And so what are the results from the first PDSA cycle? So in total, we were able to have 8 surveys completed, and they were from this range of disease sites. And I will note that there were 2 that were not recorded here. And so in terms of the very first question, so the time at which you first were connected with the outpatient palliative care team, in terms of how they felt about the timing, and so what you can see here is that all of the participants indicated that the timing was just right. None of them indicated that it was too late. And there was one person who indicated both too early and just right, but that person, unfortunately, no disease site was listed for that one, so we're not really sure, where they're at with their cancer journey. Um, so that was, yeah, these were just some of the first results for the first question. And then in terms of the qualitative section that was beneath that question, um, there were lots of comments that were left, and I extracted the most salient themes from those comments and thought it was really important to include them here. And so the main themes were help with symptoms and help with decision making or illness understanding. And I really think that, some of the strongest value comes from the richness of this data from the patient's quotes themselves. So I've actually written them out here. And so in terms of help with symptoms, sorry, I just have to move the little box. Someone said, at the time my symptoms were getting painful, we were able to explore different options. The palliative team is really helpful in managing symptoms, including dysphagia, loss of appetite, and depression. I was experiencing a lot of pain, and the referral was well timed and effective. And then in terms of help with decision making and illness understanding, they said, the team has helped and explained what to prepare for. I was beginning to understand this needs attention, and it is new to us, and we have to agree on what we're doing, but at the end, we made the right decision. And so, moving on in terms of the second question, this was more so getting at any perceived areas of benefit. And so you can see here on the x-axis, those are those perceived areas, and then the y-axis is the number of responses. And so I've just ordered them here in terms of the frequency in descending order. And so what you can see is that all patients perceived some type of benefit from our team. So no one selected no benefit. And all participants felt help with symptom management was important. But, it wasn't only symptom management that folks indicated was helpful for them. The majority of patients also found benefit in discussing advanced care planning, illness understanding, and also support from our Odette palliative nurses as well. And then this is that qualitative section just under the any perceived areas of benefit. And so only 2 people answered this question, but I thought I'd just highlight their comments here as well. So they said, the new medications prescribed by the palliative team has improved my quality of life. And it is beneficial since we are new to the problem. We learned a lot of things. Everybody is very helpful from the doctors and all people helping and nurses. And in terms of that very last question about circling the area of support that they found to be the most helpful, what we actually found is that there was an even spread in terms of illness understanding, goals of care discussions, pain, and then other symptoms. And so, it seems like people are finding it's not just help with symptom management, but also these discussions about understanding their illness and goals of care discussions are also really important for them. So, what are some main takeaways from the first cycle? Well, first of all, I think, we can see that in general, participants believed that their connection to the outpatient palliative care team was on average just right. Um, and that in terms of those areas of benefit, all perceive some type of benefit from our service. And not just one benefit, but a multitude of benefits. And the greatest perceived benefits, as I mentioned, were found in symptom management and goals of care discussions, as well as illness understanding. So, what are some of the limitations with this? So, as is evident, it's a small sample size, so N of 8. And so this means that it likely lacks generalizability to our greater patient population. Um, in terms of biases, there were inherent biases as well. The physician is the one administering the survey. There's likely that, patient pressure to report a positive experience and likely even self-selecting for patients who may even report a positive experience on top of that. And as is mentioned, it did exclude non-English speakers and limited English speakers, and as well those unable to complete their own survey. And we know that at the Odette Cancer Center and Breast Center, we have such a diverse population of patients that we see. And so I think this, it does limit, the richness of this data and all the voices that we're hoping to hear from because of that. It also didn't account for folks who may have already been introduced to palliative care. So let's say our inpatient colleagues referred to us on the outpatient team, and so they had already been familiar with palliative care. This didn't capture that. And as well, it did exclude the caregiver and family experience, which I think is really important to mention here because we know how important caregivers and family members are to supporting the journey of our patients that we see. And so this lacked their voice as well. So I think there's, specific barriers and facilitators to conducting this whole quality improvement project that need to be sort of highlighted as well. And I did ask after the fact my team members, what seemed to help facilitate providing surveys, what seemed to hinder it. And so some of the barriers that were mentioned is that it is really difficult to capture that first in-person follow-up appointment. And there's a couple different reasons for that. First of all, many of the first follow-ups are virtual. And then patients may even be admitted in between their first consultation and then when their follow-up is. So it's just sometimes difficult to hone in on that first visit. We're all busy. These are busy clinics, and it's really difficult to remember to administer the survey. And as well, I think it was just there was multiple steps with the survey as well, where the physician had to circle the disease site, and it just it created an overall barrier in terms of completing them. But I think there were facilitators as well, and what folks mentioned was were helpful were the visual reminders, so having boxes in the room, posters around the clinic reminding folks to do it, and then I sent out weekly email reminders as well. So, with all that being said, we did feel like conducting a second cycle was important just to see if we could improve on those numbers a little bit and um, see what extra voices that we could really gain from taking another look at this. So I'll get into that now. So with the second PDSA cycle, we really broadened the inclusion criteria to include any in-person follow-up time point. So not just the first visit. So hopefully we could capture more people this way. And we also included those needing help from a support person to hopefully enhance the voices that we're able to hear from as well. In terms of exclusion, we did exclude non-English speaking patients, just limited by resources with this study. So here's the second iteration of the paper survey, and it's mostly similar except for the first section. So in the first section, we wanted to capture whether it was a support person helping the participant fill out the survey, just so we could be clear if it was their voice or whose voice it was, or if they were having any help, and then whether they had met the palliative care team before. And then also we took sort of the onus from the physician remembering to circle the disease site to then asking the patient to record their site of cancer. And the first question remained the same. So looking at that timeliness piece. And then question two and question three also remain the same in terms of what areas, did they perceive that they've benefited from after being connected with us. And the intervention is mostly the same, except for the fact that the physician no longer had to circle the disease site code. So in terms of the results from the second PDSA cycle, we were able to get a few more surveys completed this time, which was great. And there was a broader range of disease sites as well. And this time there was only one disease site that was not recorded. And just to highlight those first two questions, first of all, in terms of caregiver support and previous palliative care experience, we did find that there were three participants who did receive help from either a child or a sibling. And so I think it just goes to show that it is really important to include these folks in the surveys, as we may have not heard from their voice otherwise. And then four folks actually did have previous experience with the palliative care team as well. So in terms of that first question, so the time at which you first met the palliative care team at Sunnybrook was, um, and you can see again that with the 15 responses, the majority of folks indicated that the timing was just right. There was one person who indicated that it was too early, and then four who indicated that it was too late. And then in terms of the specific breakdown of disease site areas that correspond to those answers, unfortunately, the too early responded, the disease site wasn't recorded. And then with too late, there was two from head and neck, one from breast, and one from gynae. And then in that qualitative section, again, I extracted the sort of most salient themes that came forward. There were 10 folks who had responses here. And so I've just outlined some of those responses because, again, I really do feel like we're hearing from the actual voice of the patient. So I think it's really important to highlight these responses. So the themes, again, were help with symptoms, help with decision making and illness understanding, and then timing of referral. I'm just going to move the box again. And so in terms of the specific comments, someone said, I had a lot of mouth sores and pain from the beginning. To have the pain under control, to get rid of the pain overall. Pain kept increasing and managing it became difficult. Palliative care helped with pain management. In terms of help with decision making and illness understanding, someone said for help and guidance. Someone said it was very informative. Another person said, it was done at a stable time of treatment without a negative feeling. We were given helpful guidance in case conditions deteriorated. And then finally, in terms of the timing of referral, someone said, I think I should have been referred earlier. Had that happened, I wouldn't have gone through all the pain I suffered from. And then someone else indicated midway, I wouldn't have wanted to presumably be referred earlier. And then finally, I started to have problems with the pain and chemo side effects earlier than the referral was made. Okay, now in terms of those areas of perceived benefit, all of the participants answered this question. And Here again, I've listed them in terms of descending order of frequency. And what you can see is that, again, all patients felt some type of benefit. And that symptom management, so pain management, as well as help with illness understanding and advanced care planning were the most frequently cited areas of benefit. And then in terms of that qualitative section, there were a few comments left there as well that I wanted to highlight again. So someone said, support for my family. The doctor is very compassionate. The doctor has helped us prepare for what might come while supporting and encouraging our positive outlook. I enjoy hearing from the dietitian and discussing problems with constipation. I think highlighting the fact that we work so closely with our allied health team members as well, and they're so integral to all of the work that we're all able to do in terms of supporting our patients. Understanding at-home support for the future. And finally, it was helpful when the team connected my parents with the family and support team. And then finally, with that last question of, circle the area of support that you found to be the most helpful from being connected with the outpatient palliative team. We had 12 respondents here. And so folks had a more of a variety of responses with this cycle. And you can see that the majority of patients felt like help with pain was the most beneficial support, although illness understanding was also cited to be the most helpful for some people. And then there was an even spread between support for my family, nursing support, and then other symptoms. So a wide range there in terms of what folks felt like was the most helpful. And so, what are some of the main takeaways from this cycle? So, in terms of the patient's perception of overall timing, again, similar to the first cycle, the majority of participants indicated that the timing of their connection to the outpatient palliative care team was just right. However, there were some patients who felt like the timing was too late, often referring to the onset of symptoms as a reason why. And the majority of patients did not think the referral was too early. Unfortunately, there were no real identifiable trends between disease sites and perception of timing of referral. And then in terms of the patient perception of benefits, as was similar to the first cycle, all participants reported some type of benefit from our service. And not only that, but they reported a multitude of benefit. And the greatest perceived benefits were to be found in pain management, but also in facilitating illness understanding. And so, what are some of the limitations with this cycle? I think they're quite similar, if not very similar to the first cycle. But again, it is a small sample size, which, it's difficult to extract definitive conclusions about some of these statements on. And again, the same biases were here as well in terms of, you know, patients feeling pressure to report a positive experience or even self-selecting for folks who would be more likely to report a positive experience. And again, unfortunately, this cycle two did exclude non-English speakers as the survey was in English. So in conclusion, I mean, I think that, it just needs to be stated that the sample sizes were probably too small to generate generalized conclusions about the services. But I do think, though, that there still is value in, providing directionality and as well having those, having those voices come through in the qualitative sections as well. And so I think, in general, what we can say is that the timing of referrals is generally perceived to be appropriate by these participants. And I think that probably that has a lot to do with the fact that, we're so well integrated into the oncology clinics here in the Odette Cancer Center, but also in the breast clinics as well. And so I think likely the referrals are appropriate in terms of timing. I think in terms of those few people who indicated that, maybe the referral was too late, it seemed to mostly be in response to symptoms. And so, I would just say consider referring patients early who begin to have refractory symptoms to initial symptom management. And then finally, I think, again, it did show, I think, an interesting point to us, which was that patients are not only indicating that, they only find benefit in our connection with symptom management, but it is also in those discussions around advanced care planning and illness understanding. And so I thought that that was a really special and important salient point here as well. And so what are the next steps here? So as I mentioned, I think what, I realized, and I think what many of us realize is that hearing those patient voices come through in those comments that were provided is really so valuable. It literally is the patient's voice, and we wanted to expand on that and dive even a little bit deeper into that and try to see if we could understand even more. And so the next steps for us is an expansion of that understanding, and we are conducting a mixed methods qualitative study to interview our outpatient palliative care patients and do a deeper dive into really their feelings about being connected with palliative care and what they might find to be helpful. And so I can thankfully say that our RAB has been approved for that study and recruitment is underway. And so hopefully a presentation on that in the future. um, but that's actually everything from me. Thank you guys so much for being here today. I really appreciate it, and I'm happy to take any questions that might come up. And it is also totally fine if there are no questions because it's a beautiful day. I have the benefit of sitting in the same room with one of my colleagues, and so she's telling me that she's writing something in the chat, which I will open up now. Um, okay, so I have the chat. Oh, I have the chat open. Um, so there's a question saying, my question is whether there is evidence of a switch to activate dormant cancer in other malignancies. My experience with melanoma and unpredictable cancers suggests that this can happen. I wonder, and that's from Neil Isco. I wonder if you mean like,
Lucy, I think that's from April 20th, it actually looks like.
oh, no wonder I was really confused with that question. Okay. Elizabeth Barnes says, what is your capacity, i.e., wait time for a consult? Actually, I think maybe Christine, who is here, may be able to answer that best.
Yeah, thanks, Tony, for your question. Generally, our wait times are anywhere from 10 to 14 days, but for urgent consults, please utilize the pager because, like Lucy said, it's a different doc on the pager each day. And we're always, if we can't fit the patient in, we're always happy to provide some advice until the patient can be seen within the week.
Okay, thanks.
Thanks, Christine. So Giovanna asks, does your data point to any suggestions for referring physicians in terms of practice changes or approaches to palliative care? I mean, I think it's a great question, and I was thinking about this as well because I think that's always the central point to any quality improvement project. And I think that like I said, there were a few who did say that the referral was too late, but I think still overall, it seems that the majority feel like that the referrals are happening at an appropriate time. I think the only thing I would think of, or I could think of, is that um, really illness understanding piece and advanced care planning piece, but specifically the illness understanding piece, because I think that was something that really came forward um, in the data. And that's just to say that, you know, patients are perceiving benefit to being referred to us specifically to discuss illness understanding. And so I think that that can be in the back of your mind or anyone's mind when they're thinking about referring to us. So not just for symptom management, but also in terms of referral around goals of care discussions and understanding illness. But thanks for that question, Giovanna. Yes, please. Giovanna is just going to ask another question.
I'll come off mute. I hope we don't get feedback because Lucy and I are in the same room. Um, so just, I mean, really data points to early palliative care being so beneficial in the setting of serious life-limiting illness. Um, I know this is a bit tangential to your data, but thoughts about kind of balancing early referral with capacity, because I think, in palliative care, we talk a lot about tertiary palliative care versus primary palliative care and kind of wanting to build that primary palliative care capacity in our teams, but also recognizing the importance of early referral. Just wondering if kind of being so like, enmeshed with this data, has that got you thinking about that and how to kind of best approach the benefits of a early palliative care referral with the capacity issues and kind of the capacity building that we need to do around primary palliative care? I'm not sure.
Yeah, I think that's a really
Yeah.
good question, Giovanna. And and it did come up as I was thinking about this. And I think it also sometimes brings up the question of like, should there be automatic triggers for referrals to palliative care? And I don't necessarily think that that's the answer either for exactly what you stated around our own capacity and our ability to manage those volumes. Um, I think that I think I think the benefit really comes from having a discussion with our team about, if there is a patient that you have in question, and about if we should, become involved. And that's why, I didn't say, you know, in terms of the symptoms, I didn't say, I think you should consider early referral as soon as someone has any type of symptom. I think it really should be maybe after, initial steps have been taken to see if the symptoms can come down. But considering to refer soon if initial management isn't helpful. Um, yeah, I feel like it is a tricky question or a tricky thing to find that balance between, what is our capacity versus how early should folks be referred. Um, I think that as well, like you mentioned, there is a role for primary palliative care as well, and I think that that's part of some initiatives that are ongoing right now. I know that, for example, Adam Merlot, Dr. Adam, is conducting some, road shows in terms of doing some education pieces, and I think that we're always trying to work on those education pieces as well to empower other folks to have some of these conversations as well. But I think it's always worth a conversation with our team if you ever have someone who you're not sure about um, referring to us. Sorry, that was a very circular answer, but I'm also still formulating my thoughts on it.
Thanks, Susie. I don't think that was circular at all. I think that's really helpful. I think it's an and situation. It's like, yes, referrals to palliative care are useful and helpful and beneficial in so many ways. And primary care education and primary palliative care education and capacity building is important because I think this skill set needs to be like really broadly taught and competencies need to be built across professions and across settings. So I think it's both. I think it's both and. Thanks, Lucy.
Christine?
Thanks so much, Lucy, for all your work on this. I was just wondering, I forget if we never on the survey actually captured age category on there, right? Okay. Because I
No.
wonder how responses would differ
Mm-hmm.
I'm just specifically thinking about the AYA population given our complex case rounds discussion this morning as a group. And I'm just curious what the perceived benefit could be from that population. And I think Sandy's on the call too. So maybe an interest in the future for targeting the AYA population.
Yeah, definitely. I think there was other data for sure that would have been helpful, like time from diagnosis, for example, like at what point were they being referred, their age, different things like that, which we just weren't able to capture here, but definitely something to think about for the future as well. And I don't know, maybe in some of our qualitative interviews, there'll be some different trends with that we can capture as well. Okay. Well, I don't see any other comments or hands up. So again, I just want to thank everyone for um, their time today, and feel free to follow up with me anytime after if you do have any questions. But yeah, thanks so much.